Hi, my name is Matt. I am a general surgery registrar in North West and just coming to the end of my PhD in obesity and cancer data science, which is funded by CRU UK and is a collaboration between Manchester Cancer Research Centre and Leeds Clinical Trials Research Unit. Thank you very much for the invitation today to be speaking about obesity and cancer risk. So I thought we would go through firstly a little bit about the relationship between obesity and cancer, why this is important from a surgical and a public health perspective, and then potential intervention opportunities and what the current evidence base is. So I firstly wanted to start with the understanding that obesity is a chronic disease, moving beyond that of just a person eating more than they burn off. There have been twin studies comparing mono and dizygotic twins showing that 70% of BMI variance is genetically driven, and this is really beautifully highlighted in this figure showing the difference between monozygotic twins and dizygotic twins and their body habitus. So we've gone one step further than this. A big paper in Nature Medicine just a few months ago generating a polygenic risk score for obesity in over 5 million genotyped adults. And this explains around 17.5% of BMI variance. And you can see that as that score gets stronger, the likelihood of having a BMI in the range of obesity becomes much higher. Looking at the obesogenic genes, interestingly, the predominant area where these are expressed is in the nervous system, showing how complex and multifactorial obesity is as a disease, and that actually it's predominantly central nervous system driven. And this is highlighted, as you can see, in a huge variation in treatment response. So this is a waterfall plot from a lifestyle intervention study showing the significant variance in people's response in weight loss, and the same in the select trial. So this is response to semaglutide, with some participants having 40% weight loss, whereas others gain weight. So the way that obesity causes cancer is really complex and with multiple mechanisms, and this is highlighted by an improved understanding that obesity is not just an increased number of fat cells, but it's a dysfunctional endocrine organ. So one of the pathways is by increased estrogen, which can lead to increased cell division and oxidative stress on DNA. There's also likely going to be increased insulin due to the glycemia and reduced insulin sensitivity, which will affect IGF-1 pathways, cell division pathways, and can create a favourable tumour microenvironment. Adipose tissue also increases the secretion of adipokines like leptin and TNF-alpha, and these directly contribute to angiogenesis, increasing the number of tumour-associated macrophages and growth signalling pathways. There is also considerable immune system modulation, not just by the increase in adipokines, but also in microbiome changes and fundamental changes in T cell exhaustion, changes in inflammatory metabolites, T cell exhaustion, chronic inflammation. Ultimately, all of these pathways in part contribute to carcinogenesis, tumour progression and metastasis, and may have different effects and predominate differently in individual cancer types. So in 2016, an IARC working group defined at least 13 cancer types are directly linked to the presence of excess body adiposity. And since then, there have been studies suggesting there may even potentially be more, with this large Catalan study and this large Swedish study. Thinking about how much the burden of obesity is on cancer, around 4 to 8% of all cancers worldwide is directly caused by obesity, and this equates to around 22,000 cancers in the UK each year, and over 500,000 globally. And you can see in this heat map that it's predominantly Western countries. There's a really large burden, particularly in Europe and North America. So obesity is now becoming a global epidemic. In this NCD risk collaboration study recently published in The Lancet, there has been an increased prevalence of obesity in over 75% of countries worldwide between 1990 and 2022. This equates to over 1 billion people now living with obesity worldwide. It is now the second most common direct cause of cancer and is predicted to overtake smoking as the number one cause in the next 25 years. Equating this to obesity-related cancer, if we look at global cancer statistics, and even if the prevalence of obesity-related stay the same for the next 25 years, just based on population changes, we're going to see huge rises in the number of incident obesity-related cancers, and potentially between 30 and 125% in individual obesity-related cancers. So at the moment, we don't have any dedicated primary prevention strategies, but what's the evidence underlying this at the moment? So there's good evidence that bariatric surgery significantly reduces obesity-related cancer risk. For example, in this recent meta-analysis from Wilson et al. Showing around a 41% risk reduction after bariatric surgery in obesity-related cancer. And this is supported by several studies. You can see in this survival plot from the study from Aminian et al. That divergence in risk happens at around about 5 years after bariatric surgery. What about other different types of weight loss intervention? So there is some suggestive evidence that lifestyle intervention can reduce your cancer risk. Now, it's less efficacious in terms of weight loss, but this recently published Look Ahead trial, which was an intensive lifestyle intervention for the treatment of diabetes, showed a non-statistically significant 16% risk reduction in cancer. Further meta-analysis, now this isn't published, but do support this and have helped show that there is potentially evidence that lifestyle intervention does reduce your long-term obesity-related cancer risk. Now, what about newer interventions like GLP-1s? So at the moment, it's a real challenge. There's weak evidence. There are some suggestive population-based studies that have shown quite considerable cancer risk reductions, such as this one. As well as these other population-based target trials. However, it's really challenging to interpret this given how novel these drugs are and some of the methodological challenges around understanding drug databases without the presence of a true clinical trial. So what about how obesity affects patients who have already been diagnosed with cancer? So it's been fairly well established that obesity is associated with worse cancer outcomes. For example, in this systematic review meta-analysis stating that patients have worse overall mortality, worse cancer-free survival, and higher odds of recurrence when they have obesity as compared to without. This is particularly strongly seen in those cancers that are more strongly associated with obesity, for example, breast, colorectal, and endometrial. Thinking beyond just cancer-specific outcomes and looking at surgical outcomes for those undergoing surgery, we already know that obesity is associated with higher risk of infection and other surgical complications. But what about cancer-specific surgery? So there have been a couple of studies showing that in colorectal cancer surgery, infectious complications are significantly higher, particularly with wound infection. And this has also been replicated in ovarian cancer studies too. It's also been established that obesity can impact chemotherapy dosing. So guidelines suggest recently dosing on full body weight. However, it's important to understand different phenotypes of obesity. For example, sarcopenic obesity can be associated with higher chemotherapy toxicity and worse outcomes. There is also a kind of lack of understanding at the moment around biological agent and dosing regimes and how obesity can impact the potential pharmacokinetics and pharmacodynamics and making sure that we optimize our patients' therapy with obesity. So what about obesity management as an adjuvant treatment of people who have already been diagnosed with cancer? Now, this evidence is really challenging as weight loss is a predictor of more aggressive cancer. So looking at lifestyle intervention, they can improve outcomes. We already know that prehab lends itself to improved outcomes, particularly those patient-related ones. For example, in this big umbrella review. There's also been a recent update to the ASCO guidelines advocating for weight management being appropriate in patients living with obesity and cancer. Now, thinking about other obesity management interventions, so there's emerging suggestions that GLP-1 treatment may improve outcomes. This is patients on GLP-1 receptor agonists compared to DPP-4 inhibitors with improved survival. Specific obesity management trials are ongoing. For example, these 3 tirzepatide and semaglutide related clinical trials, so that evidence will hopefully be available over the next few years. Thinking about bariatric surgery, there is an understanding that it might be feasible as part of a patient's cancer therapy. This recent feasibility study from Professor Palmer, looking at high-risk patients who had bariatric surgery, with the majority of those going on to resection with comparable outcomes. But at the moment, hopefully we'd agree that the evidence is dubious, and I think this is a really important area for further research. So 4 quick summary points from today's 10 minutes. Firstly, it's important to understand that obesity is a complex chronic disease with a broad clinical spectrum. The rising obesity and obesity-related cancer rates are currently a global health concern. Obesity treatment should be individualised and considered across the entire cancer pathway, can be really impactful to patient outcomes. And finally, we really need to prioritise further research in obesity management for prevention and alongside cancer treatment. Thank you very much for listening. If you're interested in this, please do not hesitate to reach out. Thank you.